Hello everybody. Today's topic is hemodynamics. So first is the art line. The arterial line provides the access for the invasive arterial pressure monitoring. That is, the continuous blood pressure monitoring will be possible with the help of art line. It can be used to obtain the blood samples whenever frequent blood draws are indicated, including ABGs. So typically standard 18 gauge or 20 gauge size catheter is inserted into peripheral artery, usually radial artery, brachial artery or femoral artery. So the preferred site is radial artery. So the advantage of this radial site is it is easy to locate. It has a good collateral circulation to the hand provided by the ulnar artery. It is easy to observe and maintain, and then it is anatomically stable and comfortable to the patient. Now, the disadvantages are it has a relatively small lumen, possibly making catheter insertion difficult and painful. There is always high risk of thrombus formation with the prolonged use due to small vessel size and the small gauge catheter required to cannulate it. Then there will be the always risk of nerve injury due to hematoma formation and trauma triggering catheter insertion. Then the femoral artery, the advantages will be possibly easiest artery to locate and puncture during emergency due to its large lumen. It is also anatomically stable because femur is acting as a natural splint. The disadvantage are difficult catheter insertion in the presence of atherosclerotic plaque, possible damage to the nearby femoral vein and the major nerves during catheter insertion. Then there can be the possible tissue damage if the artery occludes because of the inadequate collateral circulation. Then there will be the difficulty controlling or preventing bleeding. Then there will be the high risk of infection with prolonged use due to close proximity to the perineal area. Then the next site will be axillary artery. There will be the fewer complication with prolonged use due to large size, reduced risk of the distal arterial insufficiency due to adequate collateral blood flow. Then it is useful in the patient with the severe peripheral vascular disease. Difficult catheter insertion and it is uncomfortable for the patient. Risk of hematoma formation will be there because which increases the chances of the neurovascular complication. Then there will be the risk of cerebral air and the clot embolism during flushing of the system and blood center. The next is dorsalis pedis artery. It may be used when the other sites cannot be used because of burns and the other injuries. There will be the high risk of thrombosis due to small vessel size and the small gauge catheter required for insertion. It will be uncomfortable for patient and difficult to immobilize. Then we need to perform the Allen's test before inserting arterial line. Now we'll see. So before assessing the radial artery for peripheral arterial line insertion, the patient's ulnar and the radial circulation must be checked for collateral circulation. If the radial artery is blocked by the blood clot, then the ulnar artery alone must supply the blood to the hand. So this patency will be checked by the performing Allen's test, which demonstrate how well both arteries are sufficient to supply blood to the hand. So these are the steps of performing Allen's test. First, we have to raise the patient's arm on the mattress or bedside stand and support his wrist with the roller towel. Then we have to ask the patient to clench his fist and then using the index or middle finger, press on the radial and the ulnar artery and hold this position for a few seconds. Without removing your finger from the patient artery, ask him to unclench his hand and hold the hand in the relaxed position. So since both the arteries are occluded, the palm will be blanched because the pressure from your finger has impaired the normal blood flow. Now the next step is release the pressure on the ulnar artery and keep the pressure on the radial artery as it is, and then observe the palm for the brisk return of the color. So normally it will occur within the 7 seconds. If the color returns in 7 to 15 seconds, then the blood flow is impaired. And if the color returns after 15 seconds, that means the flow is inadequate. Now we need to take the proper care of after inserting this arterial line. We need to take the proper care of arterial line. Like we should properly dress after insertion of arterial catheter. Dress the insertion site and transparent dressings are typically used. Then immobilize that body part. The body part where catheter is placed will then need to be immobilized. The joint and the limb should be placed in the neutral position to prevent joint flexion and extension, which may result in the kinking and dislodgement of the catheter. If the radial artery has been used, then they take care not to hyperextend the wrist, which could result in the neuromuscular injury. Then assessing. So the arterial catheter site must be assessed every hour. Include the following in your assessment. Like we should inspect the arterial catheter insertion site for redness, drainage, bruising, and blanching. Then palpate the area for firmness and the swelling. Then assess the circulation of the extremity in which arterial catheter has been placed by evaluating skin color, temperature, capillary refill, distal pulses, motor and sensory function. So this is the picture of art line in placed and that proper dressing and the proper steps that and the proper things that we need to be taken care when the art line is in situ. That is, the first thing is the tubing is secured to prevent the pulling and the catheter dislodgement. Then the next, the dressing should be transparent and we should visualize the site. Then the next thing is distal extremities are secured to enable the neurovascular assessment. Then the padded splint and the arm board may be used to immobilize the extremity. Then art line should be connected to the pressurized flush solution of either heparinide solution or normal saline solution to maintain the patency. And the joint should be immobilized to the neutral position. The arterial pressure monitoring measures the arterial pressure directly using the indwelling arterial catheter connected to the external pressure transducer and the filled tubing. The tubing is attached to the pressure bag of the saline and the heparin flush solution, and the transducer is attached to the monitor. The pressure transducer converts the pressure into electrical signal that is interpreted and displayed on the monitor screen as a continuous waveform. So most commonly, radial artery is the site of the catheter insertion, and because this artery is readily accessible. Now the next step is the zeroing. Zeroing is important because the physiological pressures such as arterial blood pressure are relative to the atmospheric pressure. So by zeroing the transducer, the effect from the atmospheric pressure are eliminated. So establishing this neutral point ensures that pressure measurements reflect only the pressure value in the vessels and heart chamber wave. So this is the video. So I hope you have understand the zeroing the procedure. So this is the again the pictorial representation of the zeroing. As you can see in the second picture, the what this should be the close on the side of the patient and open to the side of the atmosphere when we are zeroing the outline. So indications of the outline when highly accurate or frequent blood pressure measurements are required for patient receiving the doses of the vasoactive drug requiring titration, for patient requiring the frequent blood sampling. Then the contraindications are peripheral vascular disease, hemorrhagic disorder, use of the anticoagulant or thrombolytic agent, areas of active infection or with synthetic graft material, then the sites of the prior vascular surgery. Then we need to understand the arterial waveform. There are components of the arterial waveform. So there is anacrotic limb, systolic peak, diacrotic limb, dicrotic notch, and the end diastole. So we'll understand the meaning of this waveform. So what is anacrotic limb? So it makes the waveform initial upstroke. It results as the blood is rapidly ejected from the ventricle through the open aortic valve into the aorta. Then the systolic peak, the rapid ejection causes the sharp rise in the arterial pressure, which appears as the waveform's highest point, and this point is called as systolic peak. Then the dicrotic limb, as the blood continues to flow into the peripheral vessel, the arterial pressure falls and the waveform begins the downward trend. This part is called as dicrotic limb. Then the dicrotic notch, the arterial pressure continues to fall until the pressure in the ventricle is less than the pressure into the aortic root. When this unequal pressure occurs, the aortic valve closes. And this event appears as the small notch into the waveform downside known as dicrotic notch. Then the next is the end diastole. When the aortic valve closes, the diastole begins progressing until the aortic root pressure gradually descends to its lowest point. On the waveform, this is known as end diastole. Now the next is flush test. So we'll see what is the square flush test. So after flushing the line, the flat line will come, and after that, we can see the oscillations. Now we'll see the how we should interpret the underdamped and the overdamped line. So this is the video showing the overdamped artery. So I hope it is clear. So after the flash test, if we are seeing the more than two oscillation, then our arterial line is underdamped. And if we are seeing the less than half oscillation, then we can interpret as the overdamped wave. So this is the waveform of the arterial line. When I was on the night duty, one patient had a atrial fibrillation. So I recorded this video of the atrial arterial waveform when the patient is in atrial fibrillation. So the complications of arterial line is thrombosis, blood loss, arterial spasm, thromboembolism, systemic infection, hematoma, and inaccurate reading. Now the next is central venous catheter. So we can insert the central venous catheter into three places like internal jugular vein, femoral vein, and subclavian. Internal jugular vein, it provides the short and direct route to the superior vena cava or right atrium. It carries the low risk of the catheter displacement and it has a low incidence of the pneumothorax and perforation of the artery than the subclavian vein. And it has a low risk of the thrombotic complication because of rapid infusion rate may be used. Now, there are several possible complications, including air embolism, common carotid artery perforation, perforation of trachea and endotracheal tube cup, and pneumothorax. Then there can be the injury to the thoracic duct. Now, subclavian vein, it is easily accessible. It enables the easy maintenance of the sterile and the intact dressing. It allows the patient to move neck and arm freely. It carries the minimal risk of the catheter displacement after it is secure, and it carries the reduced risk of thrombosis because the rapid infusion rates are allowed. Now there are several possible complications like air embolism, life-threatening blood loss, pneumothorax, phrenic and brachial nerve injury, and atrial tube perforation. Then femoral vein, it is easily accessible. It enables the great ease of insertion in patient with tortuous subclavian and jugular vein. It carries the no risk of pneumothorax and the minimal risk of the air embolism. It is possibly difficult to identify in the obese patient. There is an increased risk of the infection because it is close to the groin area. There is a difficulty in maintaining sterile and the intact dressing. Increased risk of the catheter displacement because the site is difficult to immobilize, and there are several possible complications, including inadvertent cannulation of a smaller vein. So make sure that the CV line is attached to the system. If the patient has the central venous line with the multiple lumen, one lumen may be dedicated to the continuous CVP monitoring, and the other lumen may be used for the fluid administration. So to obtain the values, position the patient flat, and if you cannot tolerate this position, then elevate the bed to 30 degrees. Then locate the level of the right atrium by identifying phlebistostatic axis. Then zero the transducer and leveling the transducer air fluid interface stopcock with the right atrium. Read the CVP value from the digital display on the monitor and note the wave. Intrathoracic pressure varies with the respiration, which affecting the CVP values. The best point in time at which to measure the CVP is at end expiration when intrathoracic pressure is closest to the atmospheric pressure. Now, the how to measure the CVP with the water manometer. To ensure the accurate CVP reading, make sure that the manometer base is aligned to the patient's right atrium. The manometer set usually contains the leveling rod to allow you to determine the alignment quickly. After adjusting the manometer position, examine the three-way stop. By turning it into any position, you can control the direction of the fluid flow. The four-way stopcocks are also available. Now, this video will demonstrate how to measure the CVP. So this is a different representation of our central line. So in the first picture, there is a central line is inserted into the internal jugular vein. In second picture, the central line is inserted into the subclavian vein through subcutaneous tunnel. And in the third picture, the central line is inserted into the basilic vein. So when the central line is inserted into the subclavian as a subclavian vein, it is terminated into the superior vena cava, as we can see in this picture. So understanding the CVP waveform. So once we have understood how to calculate the CVP. So now we'll understand the CVP waveforms. So the A waveform sequence in the CVP waveform represents the atrial contraction. X descent will represent the atrial relaxation and decline in the patient after systole. So when the atrium expels the blood into the ventricle. So as the cardiac cycle progresses, the tricuspid valve will close and it produces the small backward bulge known as CV. The atrium filling with the venous blood during diastole produces the another rise in the pressure known as A wave. So after atrial filling, the tricuspid valve open and most of the blood into the right atrium passively empties into the right ventricle, causing atrial pressure to fall. So on the CVP waveform, this decline appears as the Y descent. The A and the V waves are almost the same height, indicating that atrial systole and diastole produces about the same amount of the pressure. So this picture will represent the different waveform of the CVP, which corresponds to the ECG graph. So we'll see what are the causes of the increased CVP. So any right-sided heart failure, volume overload, tricuspid stenosis insufficiency, constructive pericarditis, pulmonary hypertension, cardiac tamponade, right ventricular infarction. Then the normal values are 2 to 6 mmHg, and the decreased pressures will result from reduced circulating blood volume. So these are the abnormal CVP form. Elevated A form will be seen in the increased resistance to the ventricular pressure and the increased atrial contraction. Associated conditions like tricuspid stenosis and the pulmonary hypertension. Then elevated V form will be seen in the recurrent flow. The associated conditions will be tricuspid insufficiency and inadequate closure of the tricuspid valve. Then the absent waveform will be seen into the junctional arrhythmia, ventricular pacing, and atrial fibrillation. Then elevated both A and V form will be result from the increased resistance to the ventricular filling, which causes elevated A form, and functional regurgitation, which causes elevated V form. The associated conditions are like cardiac tamponade, constructive pericardial disease, heart failure, hypervolemia, and atrial hypertrophy. The complications of the central venous line is infection, pneumothorax, hemothorax, hydrothorax, air embolism, and thrombosis. Now we'll see the different ports of this central line. Okay. So the next line is pulmonary artery catheter. Continuous pulmonary artery pressure and intermittent pulmonary artery wedge pressure measurement provide important information about the left ventricular function and preload. The original pulmonary artery monitoring catheter, known as Swan gas catheter, or more commonly known as pulmonary artery catheter, had 2 lumen. So current version have up to 6 lumen, allowing for the more hemodynamic information. So this is the deflated tip. So the deflated catheter tip resets in the pulmonary artery, allowing the diastolic and systolic pulmonary artery pressure reading. So the inflated balloon, the balloon wedges in the branch of the pulmonary artery during the pulmonary artery wedge pressure measurement. So as you can see on the top, that is balloon inflation valve. The balloon inflation valve served as the access point for inflating balloon at the distal tip of the catheter for pulmonary artery wedge pressure measurement. Then next is thermistor. The thermistor measures the core body temperature when connected to the cardiac output monitor. It also measures the temperature changes related to the cardiac output. The blue line is the proximal lumen. The proximal lumen, usually blue, typically opens into the right atrium. In addition to measuring right atrial pressure, it delivers the bolus injection that is used to measure the cardiac output and function as the fluid infusion route. Then the distal lumen is indicated by the yellow line. which opens into the pulmonary artery. When attached to the transducer, it allows you to measure the pulmonary artery pressure and pulmonary artery wedge pressure. This port can also be used to measure the mixed venous oxygen saturation. Then the next is the lumen. It provides the port for the pacemaker electrodes and the infusion of the medication or other IV fluids. So when the pulmonary artery pressure monitoring is used, nearly all acutely ill patients are candidate for the pulmonary artery pressure monitoring, especially those who are hemodynamically unstable, need fluid management and the continuous cardiopulmonary assessment, receiving multiple and the frequently administered cardioactive drugs, and are in shock and have experienced trauma, and those with the pulmonary, cardiac, and multisystem disease. So caution, some patients require the special precaution during insertion and the use, including those with the left bundle branch block and those for whom systemic infection would be life-threatening. There are no specific contraindication, but the relative contraindication includes severe coagulation disorder, prosthetic heart valve, and pulmonary hypertension. So this is the pictorial representation of the graph when we are inserting pulmonary artery. So as you can see in the first picture, when the pulmonary artery catheter tip is in the right atrium, then we need to be carefully watch the patient's electrogram because ventricular arrhythmias can occur as the catheter passes through the right ventricle. So this is the graph when the catheter is entering into the right atrium, and this waveform will appear on the monitor. So next is the when the pulmonary catheter will enter into the right ventricle, then it will be represented by this waveform. As you can see, there is a sharp systolic upstroke and the lower diastolic dip. Then the third, when the pulmonary catheter will, then the catheter tip is entered into the pulmonary artery. So whenever it reaches the pulmonary artery, the upstroke of the waveform will become smoother than that of the right ventricular waveform, and the diastolic portion will lose the deep dip as seen into the right ventricular waveform. This diastolic notch will indicate the closure of the pulmonic valve. Then, when the pulmonary artery catheter balloon floats into the distal part of the pulmonary artery, the balloon wedges where the vessel becomes too narrow for it to pass. It is represented by this graph. The monitor shows the pulmonary artery wedge pressure waveform with the two small uprises. The balloon is in the deflated and the catheter is left into the pulmonary artery. So these are the waveforms. The red arrow will represent the systolic ejection into the pulmonary artery. Then the blue arrow will represent the closure of the pulmonary valve, and the third is representing the end diastole. So normal pulmonary artery pressure, the right ventricular systolic pressure normally equals the pulmonary artery systolic pressure, and the right ventricular diastolic pressure reflects the left ventricular function. So normal systolic pressure ranges from the 20 to 30, and diastolic pressure is ranging from the 0 to 5. Now, this pulmonary artery systolic pressure shows the right ventricular function and pulmonary circulation pressure. The pulmonary artery diastolic pressure reflects the left ventricular pressure, specifically left ventricular end diastolic pressure in patients without significant pulmonary disease. So systolic pressure normally ranges from 20 to 30, and normal diastolic pressure will range from the 6 to 12. The mean pressure usually from the 10 to 15. Now, the causes of increased pressure, left-sided heart failure, increased pulmonary blood flow, any condition causing increased pulmonary arterial resistance, such as pulmonary hypertension, volume overload, mitral stenosis, ARDS, and hypoxia. And causes of decreased pressure, there is the reduced circulating blood volume. Now, the pulmonary artery wedge pressure reflects the left atrial and left ventricular pressure unless the patient has mitral stenosis. These changes in the left pulmonary artery wedge pressure reflects the changes into the left ventricular filling pressure. The mean pressure normally ranges from the 4 to 12. Now, the causes of increased pressure, left-sided heart failure, like in conditions like mitral stenosis, insufficiency, pericardial tamponade, and causes of decreased pressure is the reduced circulating blood flow. Now we'll see how to troubleshoot during PA monitoring. If there are no waveform on the monitor, then the chances are transducer is not open to the catheter. Transducer or monitor set up improperly. There is a defective and the cracked transducer. Catheter tip might be clotted and the large leak in the system. Then the intervention, check the stopcock, calibration, scale mechanism of the system, tighten all the connection, re-zero the state setup, and replace the transducer. If it is over a damped waveform, then possibilities are air bubble and blood clot within the catheter or tubing. Catheter tip lodge in the vessel wall. There may be kinked or knotted catheter or tubing, small leak in the system due to loose connection. Then the intervention is remove the air bubble that is observed and restore the patency to the clotted catheter by gently aspirating the clot with the syringe. Correct the launch catheter by repositioning the patient. Change the waveform configuration. That is then the chances are incorrectly positioned catheter, loose connection in the setup, faulty electrical circuit, and repositioning of the patient. Then how to intervene? We need to assist with the chest X-ray to verify the catheter location, check and tighten the connection in the catheter and transducer apparatus. Then ventricular irritability, irritation of the ventricular endocardium or heart valve by the catheter. Then the interventions are administered antiarrhythmic drug, verify the pressure waveform is not the RV wave. The right ventricular waveform or migration of PA catheter into the right ventricle. The intervention notify the provider immediately and catheter may be need to be repositioned. Then catheter fling, the causes are excessive catheter movement that may result from the arrhythmia, excessive respiratory effort, dynamic circulation, excessive catheter length into the right ventricle, and location of the catheter tip near the pulmonary. Intervention, notify the provider for catheter reposition. Then falsely increase and decrease pressure reading, causes our system is not properly level or zeroed, patient's body or the bed reposition without re-leveling or re-zeroing the system. Intervention reposition the transducer level with the phlebostasis axis and re-zero the monitor. Now the continuous pulmonary artery wedge pressure waveform. The causes are catheter migration, balloon is inflated, and verify that the balloon is deflated. And intervention, reposition the patient, reinflate the balloon adequately, and assess for the balloon's competence. Thank you, guys.